Hello. Over the next 6 minutes or so, I'm going to spend some time talking about the at-risk extubation, and in particular some questions that will help us identify patients who are at risk around the time of extubation and what we can then do about managing those patients. First, we need to define what an at-risk extubation is, and that could be defined as a patient who is at an increased risk of a difficult reintubation, should that be required, or a patient who is at an increased risk of requiring reintubation. And the important point here is an increased risk, because we know that any patient could require reintubation. And of course, if both of those factors are true, then that patient is arguably at the greatest risk. Here's some questions that I think about to try and identify patients who might be at risk at the time of extubation. The first question I ask is, were there factors that were encountered during the initial intubation that would likely be encountered again if reintubation is required? So that could be a patient who required an awake bronchoscopic intubation for a known difficult airway, like this patient with ankylosing spondylitis and a fixed flexion deformity. Or it might be a patient who had unanticipated difficulties around the time of intubation, requiring multiple attempts or specialised equipment. The next question I ask is, has anything changed since that initial intubation? And here I'm particularly referring to factors that are not likely to improve in the short term. So things like a Guardian suture for a new tracheal anastomosis, a halo brace, or perhaps an intermaxillary fixation device. What about the question, is ventilation likely to be difficult, either via face mask or a supraglottic airway? And we make that assessment based on the initial attempt. So at the time of induction intubation, was ventilation difficult? Or if it wasn't attempted during the initial intubation, do we anticipate that it will be difficult? Perhaps a patient with morbid obesity might fall into that category. Next question is the patient at an elevated risk of requiring reintubation? And that reintubation might be required for airway reasons, like progressive swelling following drainage of a deep neck abscess, or it could be due to a non-airway reason like significant respiratory disease. So once we've asked these questions that help us identify patients who are at risk during the time of extubation, we need to think about how we might merge that risk assessment with a management strategy. So first, what are the potential management strategies available to us? Well, we could proceed with extubation as planned. We could extubate the patient awake rather than asleep. We could defer extubation. We could use an airway exchange catheter, or we could proceed to a tracheostomy, which at times might be the best strategy to manage extubation in these patients who are particularly at risk. Here's some questions I think about that help merge that risk assessment with these potential management strategies. Is there likely to be a short-term improvement in this patient's airway? Is there likely to be resolution of swelling? Is infection likely to improve? Will bleeding settle? Next, what is the degree of risk? How difficult was the intubation? How challenging was the ventilation? Is the risk known or unknown? And what I mean by that is a known risk is where you've intubated the patient initially with direct laryngoscopy, you know what challenges you found and you know how you overcame them. Whereas an unknown risk might be a patient who is initially intubated with an awake bronchoscopic intubation, and you anticipate that direct laryngoscopy will be difficult, but you don't actually know that, and you don't know the degree of risk, and you don't know how you might overcome the challenges that you face. Generally speaking, an unknown risk warrants a more conservative plan than a known risk. Is there an isolated risk or a combination of risks? So are we dealing with a patient who has a known difficult airway, who has had progression such that they might now have swelling or an increased risk of bleeding on top of that known difficult airway, and they have a significantly increased risk of requiring reintubation because of an airway cause? Next, we need to ask, what is both your general experience, your number of years of practice and your number of years of anaesthesia experience, as well as your specific experience with particular techniques like airway exchange catheters. And finally, does a specific clinical scenario exist that might alter your threshold for either proceeding to extubation or perhaps avoidance of something like an airway exchange catheter? And an example of this might be a new tracheal anastomosis, where the desire to reduce ongoing ventilation post-operatively might impact on your decision making and might encourage you to choose a different strategy around the time of extubation. So just to review those questions again, some questions that can help identify the at-risk extubation. Were there factors encountered during the initial intubation that would likely be encountered again if reintubation is required? Have any factors changed since the initial intubation? Is ventilation likely to be difficult? And is the patient at an increased risk of requiring reintubation? And then some questions to help merge risk assessment with a management strategy. Are any short-term improvements expected? What is the degree of risk? Is the risk known or unknown? Is it an isolated risk or a combination of risks? What is both your general and your specific experience? And does a specific clinical scenario exist? Just two final questions to leave you with. First of all, when should we start thinking about extubation? And I'm just going to leave you with the visual representation of a few of these endotracheal tubes to get you thinking about when we should start planning extubation. And finally, why isn't deferring extubation always the best strategy for someone who you identify as being at risk? Thanks, and I look forward to some further discussion in the panel discussion about these questions and strategy related to the at-risk extubation.